Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Hello, and welcome to TCN Talks. This is my favorite time of the month. I have to work really hard just like Mark does, but this is where Mark and I do the top news stories of the month. Welcome back, Mark Cohen.
Hey, Chris. Good morning. Glad to be here. Thank you.
It's always good to have you, Mark. And so we're going to do the top news stories of the month of October. And I'm going to cue you up in just a second, but I want to share with you. I actually had a call just this past week with an interesting technology company. They're trying to break into healthcare. They've actually had some interesting success in other industries in helping with staffing challenges. So they're coming in. And so anyway, we're talking about all the challenges within healthcare. And some kind of way we got talking about you and I's podcast each month. And I told them basically what we're doing. And first off, they're like, so this guy, Mark Cohen, wakes up every morning, sifts through all the news and says, these are the top news stories of the day. I'm like, yeah. And they say, and then you and he read all of those and try to synthesize, here's the top news stories of the month. I'm like, yeah, like that's incredible. And so I have, again, a deeper appreciation for this service that you have provided for our movement, our segment, our market. And I do feel like in some respects, gosh, everybody needs to know about this. And this is also you and I's attempt, because no one would do what you do, Mark, waking up 3, 4 a.m. every morning scouring, but then how you and I sift through all this and try to synthesize that these are the top ones that we hope that you didn't miss. So before we go there, Mark, I think we started something we've gotten great feedback on. It's almost like Mark Cohen's master class on public relations and communications, and gotten some really good feedback. Like, please make sure Mark continues that. So do you have one for us this month?
I do, Chris. As we get into November, it's worth noting that it's a very busy time for news by and about hospice providers. There's Hospice Month, of course. There's Veterans Day. And there are also all these announcements and events related to hospice year-end fundraising activities, as well as year-end memorial events and activities. And often those memorial events and activities, such as Lights of Love type events, are tied up into small dollar fundraisers for their sponsoring hospice. As a result, I see probably more news releases from hospices this time of the year than at any other time of the year. So I thought it would be worthwhile to share some basic thoughts about news releases that hospices are distributing. First of all, because they're not always tremendously well written, and there's a lot of room for improvement. First of all, your news releases should be written and edited by people who actually know how to write journalistically. The news writing 101 mistakes that I see on a regular basis in hospice news releases at times, frankly, are kind of discouraging. One common mistake, beginning your news release with the time element. Like, today, XYZ Hospice announced a $5 million campaign to refurbish its 20-year-old inpatient care center. Whenever possible, the most important fact should lead your lead sentence. And in this case, today is the least important fact in that lead sentence. So why lead with it? A better lead is Hospice XYZ has launched a $5 million capital campaign to refurbish its 20-year-old inpatient center. At a fundraising luncheon today, Hospice Board Chair Mary Jones said, blah, blah, blah. A second point is the timing of a release. There are certain commonly accepted rules that are literally 2, 3, 4 generations old now as they relate to putting out a news release. And there are hospices that simply don't abide by them. The most common rule is that Fridays are for bad news dumps by corporations, by government, by politicians. If you put out a release on a Friday, journalists will assume that it's a bad news dump, as will knowledgeable lay readers. So hold your good news till the next week. But don't put your release out on Monday morning either. Monday morning is the time when businesses, hoping to influence the stock market for the week ahead, put out their good news. The news release wires are flooded with business releases on Monday mornings. Your release will just get overwhelmed by the tide of business news. So wait till Monday afternoon If you can't wait any longer, better yet, wait till Tuesday morning to put out your news release. And finally, be careful about the verbs that you use to attribute statements of fact and opinion in your release, if you bother at all to attribute things that ought to be attributed in a news release. I see so many releases these days where people are, quote, sharing a fact or expressing a fact. Those are simply not appropriate journalistic attributions. Use the tried and true action verbs like said, stated, explained, detailed, indicated. Verbs like shared and expressed just make your release look and read amateurish, and nobody talks like that. Sound news release writing still counts, and if you don't have an experienced writer on your staff, then try to find a volunteer in the community who can mentor and edit your staffer who is trying to write news releases. Always room for improvement there. So let's now look at the coverage in a month where the most popular topics dominated the coverage, at least quantitatively. Once again, in the number one position, Chris, long-term care, skilled nursing, and senior living with 61 articles, 2 a day for the whole month on average. The dominant theme, of course, was the Biden administration proposal to mandate minimum nursing hours in nursing homes, and the pushback from the nursing home industry, their advocates, and their allies, mostly on the Republican side of the aisle, in both Congress and state houses. In addition, October is earnings season. So publicly traded nursing home and assisted living companies like Brookdale and Sonida put out their quarterly statements, which continued to show slow improvement post-pandemic in their occupancy and their sales, in their expense control. Much of the rest of the coverage was the same old gamut of negative stories for the skilled nursing sector, particularly about staffing shortages. It's worth noting that there was a time before the pandemic when the nursing home industry was actively pushing back on negative coverage and trying to tell their positives. You just don't see that anymore with everything that's going on. Right behind skilled nursing, in second place in October with 57 articles, was news about mergers and acquisitions across the hospital and post-acute sector. And, given the fact that financial analysts have been saying that the period of high interest rates that we're in is going to be drying up M&A activity, it's kind of surprising to see that large a number of M&A stories in the month of October. There was coverage in a couple of markets about the efforts by California-based Prospect Medical to sell their failing hospitals in places like suburban Philadelphia and Connecticut. Those hospices that are more reliant on hospital referrals need to continue to scan the environment for troubled hospital providers in their marketplace. When a hospital runs into trouble, that could affect their stream of referrals.
Thank you to our TCN Talks sponsor, Delta Care RX. Delta Care RX is also the title sponsor for our May and November 2023 Leadership Immersion courses. Delta Care RX is primarily known as a national hospice, PBM, and prescription mail order company. Delta Care RX is a premier vendor of TCN and provides not only pharmaceutical care, but also niche software innovations that save their customers time, stress, and money. Thank you, Delta Care RX, for all the great work you do in end-of-life and serious illness care.
You're also starting to see coverage of organized efforts by progressive Democrats to force regulators to more heavily scrutinize roll-up acquisitions in the healthcare field, including the Optum-Amedisys deal. And then right behind M&A activity, in third place in October was labor and employment news with 54 articles that I ran in Hospice News Today. As we've been discussing for several months now, unionization activity and outright strikes are at a level not seen in a generation, maybe two. And it's creeping around the edges of the hospice sector. Hospices with operations in markets where hospitals are battling their unions ought to think, for example, about how to coach and counsel those of their admissions staff and their sales staff who might have to cross a picket line to enter a referring hospital, and what the implications of that might be. There were 52 articles I grouped in October under the end of life and palliative care category. Coverage of death doulas increased pretty significantly in October, particularly from the lull that we'd seen the last couple months. And I'm happy to note that there wasn't any real hospice bashing in the death doula coverage last month. Again, as in months past, there were lots of heartrending personal stories from caregivers about their palliative care journey with their loved one. And there were more than a few articles about research studies that made it into trade and consumer media about the need for better and earlier access to palliative care for certain types of patients or patients with certain types of diagnoses. General Hospice News saw 44 articles last month, Chris. The big news was continuing coverage of the Modern Healthcare Best Places to Work Awards, which saw about a dozen hospices named to the list of 75 top providers and payors, which obviously is quite impressive given the fact that hospice is not 1/6 of the payer-provider market. There also was an update.
Can I make a comment on that one? Because I got to just call that one out. Half of those were TCN members, which is pretty cool.
Which is pretty cool and says something about the state of North Carolina, too, since I think most of the TCN members were domiciled in North Carolina. There also was an update on the continuing positive movement by NHPCO and NAHC toward a 2024 merger that I classed as General Hospice News. Starting to see a drop-off after that. In sixth place, Hospice Provider News had 35 articles that I ran in October. On the positive side, there were slightly more stories about hospices opening inpatient units than there were stories about hospices closing inpatient units or closing entire locations or programs. I think the most impressive story and my favorite feel-good story ran in the highly credible Texas Observer. In Far West Texas, the headline was, "In Far West Texas, one hospice nurse brings comfort to the dying." The article rides along with and profiles the lone seasoned nurse for Midland-based Angels Care Hospice as she covers this vast rural county, Brewster County. We've spoken often about the unique challenges facing rural providers and rural hospices in particular, and the threat of rural hospice deserts. And this article put a very friendly but impactful face on those issues. In seventh position was coverage of for-profit providers, 34 articles in Hospice News Today last month. October is earnings season, and as I've noted previously, that dominated the coverage for the month for the for-profits. And for anyone new to not-for-profit hospices, get used to it. It happens every quarter. The for-profits every 3 months will dominate the earnings will dominate their coverage for the month. In eighth place, there were 29 articles about fundraising and development news. That's a bit of a bump, and it was nice to see. I do not run stories that announce an upcoming fundraiser. I only run articles about actual fundraising events that have been held. They give you a number of people who attended, participated. They give you an amount of money that's raised. I also cover grants received, capital campaigns, and the like. So I think this amount of fundraising and development coverage is a nice lead-in, at least one can hope, for the regular end-of-year development work that not-for-profit hospices do in November and December. In ninth place was coverage of home health and private duty and related sectors, 25 articles in October. The tenor was reasonably positive for the home health sector. There were numerous stories about home health innovations, specifically adapting technology to improve working conditions for nurses and quality oversight. And there were also reports on efforts by home health providers to go upstream with palliative care, about their initiatives to better sell their services, market their services to Medicare Advantage. It's an interesting contrast, the relatively positive tone of the home health coverage last month to the continuing bad news coverage of the skilled nursing and senior living sectors that we see. Finally, I had a tie for 10th place, a three-way tie with 23 articles each for news about physicians and nursing. news about medical aid in dying, and news about Medicare and Medicaid. On the physician and nursing front, unfortunately, it was more coverage of burnout. I think the coverage of burnout is actually increasing month to month. On the nursing side, there was also increasing coverage about advocacy efforts by nurses for safe staffing ratios and more hiring. On the medical aid and dying front, again, the most impactful coverage were personal essays by caregivers whose loved ones had chosen to utilize the End-of-Life Option Act in their respective state. And on the Medicare side, the coverage was largely dominated by the continued push-pull over Medicare Advantage and what it is and isn't doing for consumers and for healthcare spending. My honorable mentions, the folks that the areas that didn't make the top 10 were hospital news, grief and bereavement news, pharmacy and medication, dementia care, volunteers, Jimmy Carter's hospice journey, the pandemic, and governance, transparency, and social responsibility. A couple comments on those, not on all of them. The hospital news was mostly about closures, layoffs, financial problems. It wasn't nearly as bad as what skilled nursing saw, but it was still a very ugly picture. There continued to be a smattering of stories about the challenges facing rural providers. And as you know, I think the spotlight needs to continue to illuminate that dire issue. For pharmacy and medication, significant increase in coverage of use of psychedelics. That issue is growing, and I think both clinical and psychosocial hospice staff need to keep an eye on the psychedelics issue. On dementia care, as more and more providers, both hospice and home health, frankly, launch dementia care programs, they're earning some positive local coverage. On the governance and related issues, as we saw with progressives and their advocacy on M&A activity and fighting roll-ups, the progressives are also starting to zero in again on large not-for-profits that don't appear to be fulfilling their charitable mission and that are closing programs. Not the kind of scrutiny anybody likes. And for the Jimmy Carter Hospice Journey, I ran 8 articles last month, all of them obviously wildly positive, many of them picked up by numerous media outlets, just didn't run in a single place. And I think it's worth noting that the CEOs at both Hope Health in Rhode Island and Avow Hospice in Naples authored really well-done columns that provided a thoughtful and well-written take on what the Carter Hospice admission means to improved and timely access to end-of-life care. Those articles got picked up by numerous outlets and really spread their message far beyond the market that those two providers serve. So hats off to them. That's my quantitative look at October, Chris. I'd love to hear what you saw from the C-suite and the podcasters share.
Yeah, so I'm going to go there in just a second, Mark. I want to circle back on a couple things. First off, always thank you for the master class. I was actually just thinking about, you talked about earlier some of your professors and just how tough in a good way, and that, we live at a time where I think we kind of lost sight of the fact of mastery is through rigor and study and application. And I just know that's your heart of bringing that. So I just want to give you kudos to that. That was just pure solid gold masterclass right there. One thing that I call out that I've talked about each month is the staffing challenge. In fact, this month, I have a whole staffing category. It's the largest flagged one that I had. It was over almost 30 articles, but I've seen a stratification that I would call, first off, the challenges of staffing. The second one I call is the implications. And you started to allude to that, Mark, and I did not have that frame of reference of like strikes and unionization. And you're saying that could be a generation or 2 generations that we've not seen that in healthcare. But obviously, that is the implications. When you start getting in an untenable situation, there's just not enough staff. There's no easy solutions here. And if you don't work on the solution, then people feel like, I don't have anything else to do. I guess in some respects, looking through the rearview mirror, I guess this was almost predictable, but I also feel like it's a little ominous for where we're going. So I don't know if you had any other comments on that, but Even you're making comment about staff crossing picket lines. I didn't even think about something like that.
Yeah. What if your nurse is married to a telephone company worker who's unionized? He's going to have a real problem with his spouse crossing a picket line. But I think one of the things about the unionization is because healthcare employers try to ignore unions, there is this assumption that the unions are all about pay. And that assumption has been wrong for 40 years. When the SEIU first moved into Florida to organize hospitals in the early 80s, it wasn't about pay. It was about safe staffing. It was about staffing ratios. It was about, no, you can't take a labor and delivery nurse and drop her in the emergency department without giving her 2 weeks of training. So the unions have been talking about staffing issues and safety and violence in the workplace for 20, 30, 40 years. And people just had these blinders on that said, well, as long as we bump the pay rates and buy pizza every once in a while, we're fine. And that's not what that's about. And, we're seeing the hospitals that have been short-sighted about this, the price they're paying. And it's starting to creep into hospice. And, a good hospice administrator is going to keep an eye on that issue and, understand that this is a lot more than just what are you paying them and how many days of PTO are you giving them.
Yeah, that's why that culture, my mentor, Quint Studer, used to say culture eats strategy all day long. And I think that's going to be that in spades as we go forward. And the other thing that kind of, you alluded to this, is you see just the growing mental health crisis, the stress. We've come out of COVID, but then you also throw it into these kind of macro forces that are impacting healthcare, and people are at their wits' end. And Quint said that things that we used to call mental and emotional health tools in your toolbox for you personally, but for the people you lead, are no longer soft skills. They're now essential skills as a leader. And I feel like you've just kind of highlighted that. Mark, you said something else that I'm like, did I hear him correctly? So the number of new IPU openings was greater than the IPU closings, which that strikes me as weird because, and maybe it's just kind of my purview, since COVID, we've not seen those IPU units being filled like they used to. And so I don't know if you have an opinion on that or what you think that might be about.
Well, combination of openings and refurbishing or expansions. I think some hospices see an opportunity in competitive markets, see an opportunity to differentiate themselves from the mass of newcomers who are coming into their market and trying to skim market share. I think that part of it is, it's a dog wagging the tail in terms of capital campaigns are the easiest money to raise in a lot of ways. People are more comfortable writing checks for bricks and mortar. I think you also see some of these units are tied to program expansions. One that hasn't been announced yet that I'm familiar with is tied to the opening of a PACE program, but there will be hospice inpatient there. So I think in some cases it's those hospices that are trying to go further upstream, and they need a physical location to do some of that work. So I think it's a lot of issues like that. I think also it might just be that there were maybe a bit fewer closings of units in the last month too, so that comparatively the difference stood out. But the bottom line is it's not all just units closing.
Yep. No, that's good. And actually, you got me thinking about some projects that we're working on. And so maybe that's a good promising trend. Mark, before I jump in, I always kind of ask you, because, my purview, I'm trying to think about what do C-suite, hospice, palliative care leaders, but also staff need to know. What's just your general gestalt? And so is the volume more this month? My perception is it was pretty similar. I flagged slightly more than I did last month, but any comment as far as just the general gestalt?
Yeah, it was the really common topics had more coverage, and just the general run of the mill topics were either flat or a little low. So overall, it was about the same, but the mix was different.
And in the show prep, you mentioned something almost like ominous signs on the dashboard. Did I interpret you correctly? Maybe ominous is too strong of a word, just some warning lights on the dashboard.
Well, just we were talking about just the various warning signs out there in terms of pharmacy deserts, healthcare deserts, hospice deserts, hospital deserts, staffing. So a lot of red lights, or at least yellow flashing lights going off right now. And hospice leaders need to be more aggressive in their issues management. They need to be peeking out over the edge of the silos in which they operate, and they need to be scanning the horizon and not just focusing on their sole market where they're doing business.
Well said. And that's a perfect segue then, Mark. So this month I flagged 125 articles, and either I'm a slow learner or I'm just catching on, but I'm now seeing that there are common themes each month and they're not budging very much. So I'm going to do my report out just slightly different this month. So I'm going to go over the themes and I want to dig deep on two of them. First theme that I'm calling out, just because I have been raised in nonprofit and mission moments, I think reconnects us to why we do this work. But the articles that you cited from President Carter, and then again, shout out to Diane and Jason. They did an awesome job. There's also a cool article in kind of that category, I'll call mission moments again, about a hospice patient goes skydiving to check off an item on the bucket list. And so, about adding life to days when days can't be added to life. And that to me was just a beautiful one. We know not every hospice mission moment's like that, but when you do see it, it's pretty awesome. The next category is the staffing. And again, I probably had close to 30 something articles. My three categories, I'm now having to sub-stratify staffing because it is consistent. And I think this is no easy solution. That's why when we were talking about the modern healthcare best places to work, and then the implications, which is like, unionization, striking, as resources get scarce. I'm a student of history, so are you, Mark. People go to war when resources get scarce. Well, in some respects, when this is exactly what's occurring. Staff feels like, I don't know what else to do. And if leaders aren't working on the problem, because there's no software you could go and buy. There's not a quick task you go put in place. This is a huge issue that's going to literally play out the rest of my career as the silver tsunami continues to crash on shore. So my substratification is the challenges. So there's about 9 articles just painting the picture of the challenges. There was a really good one in CNN that healthcare workers face a mental health crisis. And that was a really good article, kind of unpacked all the different challenges. The second substratification, I call it the implication. So what we're talking about is the unionization. I've never seen this number of strikes in healthcare in my career, going on 28 years now. And so like Kaiser Permanente, in Pittsburgh, nurses were rallying for a 31% hike in starting wage. There was an article, I'm not sure if I actually highlighted on mine, but in the negotiation, Mark, you probably remember it, the CEO basically said, we may take away benefits. And I thought, wow, that's a strong negotiation tactic. And I just think, okay, you might win the battle, but you're going to lose the war because of where this thing was going. So that one just, it almost leaped off the page. So that was the second category of staffing I called implications. But maybe a little bit of light dawning on the edge of kind of the horizon here is what I call solutions. And this month I saw about 13 articles, just different ways people are working on this. Like one, it was an Axios article, hopes to remedy the nursing shortage with international students. Some great articles about just home health, home care, what people are doing to address the staffing woes. Of course, there are a lot of interesting articles about like kind of the gig economy and technology that allows people to take shifts. So you see a lot of that. And of course, those are going to be sexy because it has the allure that it's a quick fix, but at least they're working on the solution. There's a $1.6 million grant to help older workers train for CNAs. And so a lot of good articles, again, about solutions. So that was my second big category. Third category, I just call it reimbursement. Lots of articles, about 13 in that category, some good, some challenging. The good is ACO REACH has actually saved over 300 million, almost 400, 371 million. That was pretty positive. Let's see here. Congress calls on CMS to revise proposed hospice special focus program, the SMFP. First year of hospice VBID is the hardest for payers and providers. Risk adjustment rules may affect palliative care companies. So just again, 13 articles. I'm not going to cite all of them, Well, Mark, one I wanted to ask you under that one, because this just came out yesterday as you and I are at the end of the month here taping the show. So I've never seen someone sue CMS and actually then win. So Home Health sued because they were going to get a rate decrease. And then it came out yesterday that government is reversed. Now, it wasn't a huge, but I think they were looking at a 2.8% decrease. And I think they ended up getting it was basically a delta of about 3%. It was a little bit better than break even. Have you ever seen that in your life where someone sued CMS over a proposed rate cut or whatever, and then it actually kind of they end up kind of winning?
Well, we've certainly seen cases where CMS puts out a proposed rate and then they walk it back partially. And that's what happened here. I mean, was the suit a legal tactic, or was the suit a public relations and public policy tactic to rally their troops on Capitol Hill and in the media to put pressure on CMS and the Biden administration to not go through with the draconian cut? Was the suit a rallying cry to the thousands of members of the National Association of Home Care and Hospice to pick up the phone, to get on email and contact their member of Congress, their member of Senate, their senators, and encourage them to call out CMS to reverse the proposed cut? So, was it a tactic or a strategy? I'm not a regulator. I'm not a regulatory lawyer, so I don't know whether anybody's sued like that before. But to me, it looks like it's part of a typical lobbying, grassroots. It was an essential part of a coordinated grassroots lobbying campaign.
Yep. No, that's good. And I think all of us need to put that back in our memory banks as we journey into the future. So my fourth category I call warning signs for healthcare. And you're going to see a lot of themes here, but there are several articles. But out of those articles, staffing challenges, reimbursement challenges as value-based care, as we move more to value-based care, while dealing with actual cost and inflation. And probably the biggest article I think kind of summed it up was, I didn't realize I'm calling out so many Axios articles this month. But this one was called Warning Signs for the U.S. Healthcare System Are Piling Up. And just talking about the confluence of all of those things I just called out. And then there was a Modern Healthcare article about dozens of hospitals, health systems are seeing credit system downgrades. And Mark, I think your adage is we need to be aware, because as hospice and palliative care providers, if hospitals catch a cold, does it implicate us even worse because we're further downstream? Now, I'm starting to have a little bit of a different viewpoint. I think that at least the hospices we work with, they've gotten really smart and in serving their mission. Their tentacles are in all parts of the community. We have as good relationships with the CCRC and home health agencies as you do with a hospital, but still a lot of our communities, you think about the number of people employed and work in hospitals, et cetera. And I think that usually the biggest confluence, I think, of bond ratings, right, Mark, I think is like in the spring. So I think that's something we're going to have to watch for in 2024. Now, there are a couple of articles start talking about some hospitals are starting to turn the corner. So maybe by the time we get to the spring, and I think basically what they'll do is either they downgrade or they put them on like a performance improvement plan. But that just felt like a red light on the dashboard. Any comments to that?
Yes, I think there's two ways to look at that. When hospitals get a cold, do hospices get pneumonia? One is, my concern with that is more on the governance, transparency, mission fulfillment issue. When Senator Charles Grassley of Iowa starts going after the largest hospitals not-for-profit hospitals, because he claims they're making too much money and not spending any money on mission, that puts every mission-driven provider at risk. And I think we need to separate that from the financial good news, bad news, whatnot. Most hospices, fortunately or not, dependent on bond ratings the way capital-intensive hospital providers are. So I think there's a bit of a dichotomy there. Hospitals are at risk on the financial side. Hospitals are at risk on the reputational side. I think the greater risk for hospices in many respects is any bleed through on any cracks in the wall of mission fulfillment on the social responsibility side.
Well, my next category, Mark, I would call it demographic trends. And again, I think that my categories aren't going to change much, but this is when I want to just call out a couple of things. So here are some articles I put under demographic trends. Number one, do dementia villages actually work? And we just don't know was basically kind of the kind of punchline of the article. Why more seniors are living in poverty. I heard Joan Tino give a great presentation about the demographics of that as we go further into the baby boom population. Frailty levels decline. Health trajectory improves after nursing home stay for acute patients. That was kind of interesting, maybe positive for them. Home-based primary care can lead to modest improvements in avoidable hospitalizations. Hospices bought by PE, private equity, public companies had more dementia patients. Again, this is kind of, you call it statistics demographics. New report reveals caregivers' greatest needs. That was a really great article by McKnight's, Training, Education, and Resource Needs. A Modern Healthcare article about how one hospice has built trust in LGBTQ patients with SAGE certification. Washington Post, life expectancy in the U.S. is falling amid surges in chronic illness, which in some respects, I guess we've been kind of predicting for a while, which is why we knew the silver tsunami is going to be something we have to be aware of. In a Wall Street Journal article, more men are taking care of their aging parents, and the learning curve is steep. So I just want to call out those because a lot of demographics. Now, my next category was, I just call it innovation. Lots of interesting technology innovation like PAPA, digital health literacy program helps PAPA improve members' access to care solutions, and just a lot of great articles about just different technological or kind of care model innovations. And by the way, as Mark and I call these out, again, we could take a 3-hour show just trying to go in depth in all these articles. Mark and I are always, you guys just have to send us an email. We'll give you a download of basically these articles that we flagged, and we'll get you connected with Mark to actually get subscribed to Hospice News Today. So that way you could be reading the same daily that we are. But then again, we kind of synthesize and say, here are the ones that you shouldn't miss. So the seventh category, Mark, you called out as well. A lot of interesting articles about Medicare Advantage. Again, this to me is a category that's not going to change. There was one that I wanted to call out. It was related to care. It actually surprised me, but then I talked to Peter Benjamin earlier this week, and he had said it out loud. It was basically about minority populations that, here it is, Medicare Advantage growing among people of color who live in rural areas. And I guess I just had not considered, but the fact that, this is the way Peter described it, it made so much sense to me. He said, if you think about people that have a lot of minority populations because, they're either below the poverty line or struggling with means, having any health insurance, and then to be able to sign up for a Medicare Advantage plan to get all these supplementals, you can see why that'd be incredibly attractive. And it just stuck in my brain when he said that. I'm like, of course. And then I saw the article about actually citing the statistics there that actually amongst minority and people of color, that MA is growing quite a bit. So that's the Medicare Advantage category.
Yeah, Chris,
this category.
Just on that, the flip side to that is when you look at that question from the perspective of rural hospitals, and the line coming from the rural hospitals is Medicare Advantage is killing us because they're just killing us on rates. So there's good and bad there.
Almost a mismatch, right?
Yeah.
So the customer is signing up for more Medicare Advantage, but then when they try to go to the hospital, it's then having the impact in long term and maybe closing their local community hospital because they can't survive with those Medicare Advantage rates to the hospital. That's a great call out. The next one, Mark, is after Medicare Advantage. I just want to spend a little bit of time on this one, but pharmacy. And so I flagged about 6 articles this month on just challenges in pharmacy. So probably many of you have heard in the news, are Walgreens and CVS pharmacists going to walk out? And so there's an article about that. Other chains are walking out again, CVS, Walgreens. Iowa's lost more than 10% of pharmacies since 2008. Pharmacy desert, shortage of pharmacists leaving main customers in peril. Washington Post, drugstore closures are leaving millions without access to a pharmacy. Rite Aid Health, Florida Rite Aid's bankruptcy plan stirs worry of new pharmacy deserts. So I reached out to a mutual friend of you and I, and I'm like, what's going on? And here's my perception of the executive summary. And I think it's an interesting It's a cautionary tale to where we could be headed as hospice and palliative care providers. And first off, we know, just listen to the news, right? Pharmacy manufacturers and what you pay in America for a drug compared to what you go to South America is crazy. So that's one part of it. But then you put these PBMs in the middle, which could be where we're headed with, how do we get to Medicare Advantage plans, et cetera. You've highlighted a couple articles the last couple of months. I think it was Sanchin with SCAN is like the middle people between MA providers are horrible. Well, in some respects, that's what the PBMs have become. And they have this interesting, I'm not going to geek out, but I think it's called a DIR. It's basically a charge that they charge these local pharmacies. So the local pharmacies at the tail end of this healthcare food chain, and they're getting squeezed by the middle people, the PBMs, and of course the manufacturers. And the places that they used to make their margins are going away. At the same time, we all know staffing is a challenge. It is in the pharmacy as well. So you're getting inflationary pressures on the wages. And these pharmacies are just, they have nowhere else left to go. They've lost their past high margin products, if you will. And then one interesting observation, this one's a little bit more of a hypothesis than substantiated, but I didn't think about it till this person shared. At Amazon is now cutting into more of the over-the-counter, and the over-the-counter in these pharmacies was one of the last places they still had margins. So now people are getting their over-the-counter meds. So all of that is confluencing at the same time. So Mark, I don't know if you have any comments, but that to me was kind of eye-opening. And just one more, especially in the rural areas, just one more challenge where if you don't have primary care, you don't have a local community hospital, sometimes a pharmacy is the last part of healthcare that you have.
Well, I think on the OTC issue, I had this thought just this morning, actually, because my closest CVS is a suburban CVS, and there are very few products that are locked up on the OTC shelves, but there's also another CVS downtown that I patronize, and like everything is locked up. So if you want to take anything off the shelf that costs more than a couple bucks, you have to go find a staff person who doesn't exist. And that person has to go knock on a door and get a key from a manager to open something up so you can buy a $20 item. And I say, you know what? At that point, it's easier to sign on to Amazon and have it shipped directly to my door. So as retail pharmacies in higher crime areas deal with that problem by restricting access to product on their shelves, they're just driving more people to Amazon or some other mail order fulfillment to get their high markup OTC products. So just another problem for the retail pharmacy industry.
Well, just to round out then my number 9 category was the nursing home mandate. And I actually, I think that's another cautionary tale. So our legislators' infinite wisdom, you have a staffing problem in long-term care? Well, we're going to mandate staffing levels. Well, you can't mandate something that is such a systemic problem. Are you going to mandate that people have more children and then they go to nursing school and you crank them through nursing school quickly and they go to long-term care? We're not really working on the problem via mandate. I kind of get the spirit of it, but that is causing a lot of consternation. I had almost 12 articles kind of flagged in that category. And then my 10th category, rounding out my top 10, is merger and acquisition. So that's my top 10. I had about 7 honorable mentions, probably the biggest one to call out, or maybe the 2 biggest ones. The ransomware attacks just continue to be concerning. And then you called it out. I don't call it attacks, but the calling out of nonprofit hospitals. And are they really fulfilling? In fact, that was the one of the articles. Nonprofit hospitals must live up to their end of the bargain. And then hospital lobby clash over a nonprofit service. Again, just interesting, kind of another cautionary tale for us in the nonprofit hospice space. So, Mark, any final thoughts before I close with our quote?
We are we are condemned to live in interesting times.
Yeah, the Chinese parable, may you live in interesting times, which is why Mark and I do this. I was thinking about it, and it's hard to then try to also say, guys, these are the warning signs, but here's all the solutions. That's not the point of this show. But as Mark alluded, that as hospice and palliative care leaders, we can't put our head in the sand, and which is a perfect segue to the quote that Mark picked out for today. It's actually from Indra Nooyi, the ex-CEO of PepsiCo. It says, lifelong learning is a survival mantra of the future. Lifelong learning. Leaders must understand coming trends and technologies. That's why we do this show. They must study whatever's driving change in depth. they must go back to being students. And I think that's a great piece of wisdom. Again, Mark and I are always reach out to us, shoot us an email. There's always a link in the summary of the podcast. We're glad to share with you these articles. At worst, at least by listening to this, you'll be more informed of these kind of warning signs that are coming at us. So that way, all together, we can kind of navigate this future, because the work that we do in hospice and palliative care is so impactful. It's so important. We know we walk on sacred ground, and we have to lead to make sure that we're here 10, 20, 30 years from now, so that wonderful care is still being provided to those that need it. So Mark, thank you as always. Appreciate
Thank you, Chris. Appreciate it. It was
and to
fun.
our listen. Yeah, absolutely. And to our listeners, thanks for listening to TCN Talks.